'cause about this time of the season, the whole city supporters say, "Oh well, there's always next year." Anyway, it's interesting that doing this presentation now, because we're building on sort of what was said this morning. And to be honest with you, when I agreed to speak on this subject, I didn't know what was going to be said this morning at all. I didn't know the subjects or anything like that. But what we've got here does link into this. And whether you think you're a commissioner or think you're a provider, it's valid for you. There's all sorts of things in here. Now, this has been said, is my 3,715th attendance at this conference. And, but this time, for the first time, welcome to my day job. This is what I've set up to do, if you like, within NHS Sheffield. For those of you not familiar with the arrangements in England, primary care trusts, much maligned by Andrew Lansley, do still exist, and they basically manage primary care issues, including the commissioning of secondary care from providers, well, any provider, whether that's NHS provider, independent organisation, healthcare organisation, voluntary service sector, anything like that. There's also a community side to primary care trusts, which are typically the community nursing teams and this sort of thing, and so on, and they are going to disappear very soon and be taken on board mainly by acute trusts and other things. So, you know, we've covered all of the Sheffield Primary Care Trust covers all these areas, which is why I got Sheffield PCT on my badge. But because it's a commissioning organisation, I'm going to talk from the NHS Sheffield. It's just a slightly different branding within the same overall organisation. So, I'm going to cover three strands, basically. This is about working with providers, talking about clinical audit and effectiveness in service development, reconfiguration, or whatever, however you want to call it. This very much builds on what Miriam was talking about this morning as well. And also, believe it or not, we actually do quite a bit internally as well. There are a number of areas which I'll cover in due course. So, working with providers. Why do we need to work with providers? Well, we are a commissioning organisation, therefore we are commissioning care. So we need to work with them rather than against them. There's no point trying to impose anything on anybody, e.g. a 30 limit on a dual carriageway. You know it's not going to work, I know it's not going to work, and we all do 29.9-ish, don't we? We don't. So, you know, let's be reasonable about this. This is how it works with providers. We have contracts, we have priorities, we have agreement, we have monitoring, we have to do assurances that everything's going all right, and we report to board. There's all sorts of aspects in this which will build up as we go through, and you can see how it works. And these are contracts that are monitored and acted upon if people fail. There are financial penalties, there's all sorts of things that we can do if necessary. So really, we want to develop a set of shared responsibilities and a shared agenda. And one thing about taking this route is that because we work as a community, so I look after the whole of Sheffield, it doesn't matter who provides the service. We're all in it together. And so therefore, this method brings about a lot of joint working between organisations. It forces it almost on people if they didn't want to do it in the first place. I am very pleased to say, touch wood, that this is not a problem in a general sense, but it does highlight the need to do it well. So, in the contract for clinical audit, there are specific entries in clinical audit, in the contract, well, in the quality schedule in the contract, for all providers that state that you will conduct audits as per the Commissioner Priority Programme, and I'll look at that in a minute. You'll be compliant with HQIP criteria. We're all familiar with HQIP, yes? There'll be no Healthcare Quality Improvement Partnership. hquip.org.uk. It's got a load of resources on there which will come through in due course. You can sign up for the Clinical Audit Forum, you can share information, you can do all sorts of things with it. And if you're not registered with it, I would heartily recommend that you do so. But anyway, it produces criteria for quality clinical audit, and it's part of the contract that we require our providers to do that. We also require them to act on the recommendations of audits. So audit is not a tick box exercise for academic purposes only. It's there to actually improve the quality of care. And in doing so, we require quarterly updates of progress. We require all providers to support clinical audit in all areas. So whether or not it's a part of a contract or not, nevertheless, if the contract doesn't include any dermatology audits, we still require them to support dermatology, should they have any internally to do. And we also require them to produce an annual report. Quite a lot of stuff there. Looking at the contract for clinical effectiveness, this is our contract in Sheffield, based on the one that exists for Yorkshire and the Humber Strategic Health Authority. It does not necessarily reflect exactly what NICE says. For Chris's, obviously, to give Chris an opportunity here. But basically, what we say is that all organisations will comply with all relevant NICE technology appraisals within 6 months of their issue, unless otherwise agreed in advance. Incidentally, some of the NICE technology appraisals have had a 1 year lead-in time. There have been about 5 of them, but most of them require funding of the appraisal to be in place within 3 months. So we say, well, if we're going to do that, you're going to comply. So unless otherwise agreed, we expect everybody to comply within 6 months. All other relevant NICE guidelines, whether that's public health guidelines or clinical guidelines or diagnostic guidelines or medical technology guidelines or any of these, we would like them to be compliant within 3 years of issue. Some of these documents, if you're not familiar with NICE clinical guidelines, particularly are rather lengthy, have many standards and comments in there, and obviously can take quite a long time to implement. So we've taken a view, 3 years is sufficient. Going on to NICE quality standards, which Chris talked about before, we expect there to be a dashboard in place for the relevant quality standards within 6 months of issue. So you will be able to look at the standards and say, we comply, we don't comply, but at least there'll be something there, rather than just a black hole. However, we expect everybody to be compliant with the relevant NICE quality standards within 2 years of issue. So you have 2 years to get your act together to comply with the standards, which may say something like, we expect everybody to have a I don't know, a scan, or we expect everybody to be out, discharged alive, or whatever it is. So there's a lot of things in there about clinical effectiveness in the contract. This is specified. So you sign up to provide care for our patients in Sheffield, this is what you must do. And we actually require a quarterly update of progress. We'll come to how this works in due course, and an annual report. And that's for clinical effectiveness, as well as one for clinical audit. There is a difference there. Now, because the reason we do this is because we want to be the best. We want to be up there with world-class commissioning. It was referred to this morning. And one of the competencies says you must lead the NHS locally. So this forms part of that. We also obviously want to deliver best care. But as far as England is concerned, there is a tariff for every procedure, just about, apart from in mental health at the moment, which is coming in 2013 in draft form, so I believe. But it says that if you provide, you do this intervention, this procedure, it's going to cost, you are going to charge, or it's going to cost £1,000, £2,000, £10,000, whatever. But money for auditing effectiveness is included in the price of that procedure. Now, it doesn't have to be much as a percentage, because if you take a £100 million contract with a trust and say it's 0.5%, that is a £500,000 to be spent on clinical audit in that trust, in that organisation, in that year. And that is direct cost, not indirect cost. Now, the percentage is actually lower, I'll be honest with you, but I'm using this to illustrate the issue. And there's nothing fixed, but generally we're speaking about 0.3 as it happens. But on the other hand, many organisations in England have budgets, income if you like, of much more than 100 million, And to some of the large teaching hospitals, which I'm quite familiar with, it's talking about £600 million a year. So we expect quite a lot of money to be spent on clinical audit. Now, if it's not spent on clinical audit, or it's not been done properly, then we have the opportunity, it says to us, to spend that money elsewhere. It's like anything else. If we're going to give you £1 million to do something and you don't do it, well, quite frankly, why should we give you the £1 million in the first place? We can find lots of other opportunities to spend that money on healthcare. So we need to be assured that audit is being done systematically and robustly in order for that expenditure to be justified. Also, we require it to be integral to the culture and not just, say here, an add-on to tick a box. It's something that's integral. You do this as part of your normal care. And that's quite obviously quite important. It's so easy to have a clinical audit department or people working in clinical audit who are, or the management think, what do they do? Where is the value that they give to the organisation? As soon as that starts and there are, shall we say, savings to be made, I think there's an easy target there. So it's very important to make sure that's done. Now, as far as the commissioners are concerned, they actually need to be aware of what it is they're going to be commissioning. So we need to be aware of national priorities, regional priorities, local priorities. And so we actually, on a regular basis, not just once a year or anything like that, look at the key national drivers for clinical audit, particularly, whether they're from HQIP, whether the Department of Health or the National Clinical Audit Advisory Group, who provide advice and guidance to the Department of Health on what national clinical audits particularly should be done, and other issues around that. We have so-called confidential inquiries, which are now being called Clinical Outcome Review Programs, or CORPS, which is unfortunate because there's one on death in there, patient outcome death. Obviously, national service frameworks, as far as England are concerned. We pay due attention to NICE guidance, of course, and other aspects of NICE work. Royal colleges produce important information, as does GMC and the NHS Litigation Authority. These are our main drivers in England. We need to be aware of all these. There's a lot of documents produced under these headings, and every time you produce a document, I quickly go through and find, if it's a PDF, find audit, find effectiveness, and find NICE. If I can't find any of those three words in there, I ignore the document. It takes 5 minutes and saves an awful lot of time. So anyway, to look at our priorities, we have had an annual priority audit programme in Sheffield since 2001. This is a list of priority topics. We'll come to the list in a minute. But the process is that we go through, as commissioners, November, December, and come up with a list based on our knowledge of what we've been gleaning throughout the year so far. So it's not as straightforward as it sounds, because we say, well, you know, we think there's going to be the audit on falls and this sort of thing in 2011-12. There was one last year. It looks like it's ongoing. But then we have to contact the organisers and others to say, is it going ahead? Are you going to be doing data collection? Is it going to change? Are there going to be additional features? This sort of thing. So there's actually quite a lot of communication done in November, December particularly, to determine what is actually going to happen in the year ahead. Now we come up with this list, and just before Christmas, as a present to the organisation, we share this draft list, colleagues in the commissioning side. These are our commissioning leads by condition, topic, and various things like that, whether it's maternity, whether it's emergency care, or whatever. So they all get a copy, they all get a chance to see it. It goes to all our public health colleagues. It goes to our medicines management team. It goes to people who actually manage the contracts with providers, just in case there are problems there. And it also goes to performance monitoring, because they will need to get things set up and comment on it, things, if necessary, to make sure that the processes of performance monitoring are run smoothly.